It's a pleasure to be here, and yeah, one of those good economists. I was actually told recently I had to do a presentation where most of what I was talking about were the various measures we were including in a survey that we were doing and a data collection effort, and somebody said at the end, "You sound almost like a developmental psychologist." Like I was, yeah, I'd really turned around the corner or something and was no longer sounding like an economist who, most of the time, I don't really care that much about the measures that we're using. Just, somebody else can pick them. I just want to know about, what are the effects of what we're doing and that sort of thing. But I'm gradually, over the years, becoming even more and more multidisciplinary in my thinking. Let me just, say a couple of words about MDRC before we start, because not everybody will know, what MDRC is. We are, as Marcia said, a social policy research organization, and our mission is to study government programs and policies and services to help improve the lives of low-income families. So we do a broad range of stuff from preschool, early childhood kind of things like the child care study that Marcia mentioned, to K through 12 education, post-secondary education, especially focusing on community college work, to sort of going up, you think, as people get older, to issues around employment, and welfare receipt, which is where MDRC really started, and studies of low-wage workers and the working poor and how to improve employment retention and help people advance into better jobs, and studies about the hard-to-employ, criminal justice, and people with depression and things like that may have more barriers to go to employment. And the study I'm going to talk about today is more of the latter type. Over the last few years, 20 years ago, MDRC did almost exclusively studies about welfare receipt and employment and welfare to work programs to get people to go to work. In 1996, the federal welfare reform basically transformed the welfare system, and a few years later, nobody was really interested in welfare studies anymore, so we kind of had to broaden our areas. And one that was a natural connection was to look at people with disabilities and to think about how to think about employment among people with disabilities, and the study I'm going to talk about today is one of those. I think it's really interesting because it ties together two strands of research, one about disability and employment and one about healthcare and health insurance, and I'll talk about that. Oops. So before I go too far, there's a huge study team that was involved in this study. Just mention a few people. David Butler at MDRC was the project director, so he oversaw everything going on. The co-PIs were myself and Dave Wittenberg at Mathematica Policy Research, and we had some folks down the street, kind of at Group Health Cooperative, help design the interventions that I'm going to talk about, as well as Michael Sullivan, Vic Sullivan from McGill University. And you'll see as I talk, these guys are all mental health professionals. Two of them are psychologists and one's a psychiatrist, and that really affected the interventions that we came up with in ways that some people might think of as good, in some ways, maybe not as good. But they definitely, and then I should mention the Social Security Administration funded this, and the two folks at the bottom were really helpful and had lots of great comments. So let me just give you a quick overview of this thing called accelerated benefits, what the interventions were, what the goals were of the study, and then get into some of the details. So I'm actually going to be talking about two interventions today, both focused around health care benefits. One provided people who didn't have insurance who were on disability insurance with health insurance. I put insurance in quotes because for regulatory purposes, we couldn't call what they were getting insurance. They're health care benefits, but they would have had to go through state regulatory procedures if we had actually called it insurance. So, but then calling it health care benefits just sounds kind of funny, so we'll call it insurance today. So one provided people with health care benefits. These are uninsured people, and with the goal of helping them get more care. The other, we had discussions with some experts really early on in this study where people indicated, health insurance is important, health care benefits are important, and people aren't getting all the health care they need. But that's not going to be enough if the goal is to get people into employment. So you should add some services onto that to see if that would help people go to work. So the idea might be that health benefits get people healthier, and then some other employment supports can help them move from there to the point where they can return to work. So two interventions. And the research questions are just, when you provide people with health care benefits, do they actually use more health care? If they use more health care, do they get healthier? If they get healthier, are they able to do more things that will get them moving on the path to employment, looking for work, getting other employment supports, and do they actually return to work? And then finally, how much does it cost? And certainly from the government's point of view, there are going to be lots of questions about, is this the best way to spend money to solve these problems, or are there other ways to do it? So let's step back a second and talk about the motivation for some of these things. So you may have seen a figure like this before, that this is a trend of the number of workers receiving Social Security disability insurance benefits. It starts in 1980 up to about 2010. And in the 80s, the rolls were pretty stable at about 3 million people, 3 million workers. This doesn't include dependents and others who are receiving benefits through disability. I should also say, there are two major federal disability programs. The other is supplemental security income. This doesn't include that group either, and for reasons I'll talk about in a little bit. We're not talking about the SSI folks. And then in the 80s, the rolls just started to grow, and they've tripled, I think, since then. They're up to about 9 million people. Spending went from about $17 billion in the early 80s to over $100 billion now, and people are projecting. A lot of these projections just do a straight line and assume it's going to go up forever, but people are projecting it's going to go up 70% over the next 20 years or something like that. So it's a huge issue. On the one hand, it's great because people are getting benefits who have suffered a disability and need help. On the other hand, the federal government is worrying about all the money that it's spending, and as we all know, the Social Security system in general is running out of money, and people are projecting that over the next 10 to 20 years it'll run out of money and that sort of thing. So it's an issue that is troubling as well. So one of the weird things, one of the way that you qualify for a disability insurance benefits, there are two parts to it. One is that you have to have a work history in order to qualify for DI. If you don't have a work history, you can qualify for SSI, but not DI. The other is that you have to show to SSA's, the Social Security Administration satisfaction, that you are not able to work and earn above about $1,000 a month, something called substantial gainful activity, for at least a year, or that you have a condition that will lead to death. So it's kind of funny when you look at this literature, given that you have to show that you can't work, essentially, for at least a year, that the focus has been on how do we get people to go to work. So lots of people on the rolls, and the reason is that I think there are really only two ways that people who are still alive get off the rolls. Well, three ways. One is that they reach 65 and they get Social Security retirement benefits. Another is that they go to work, and they show they can work, and then they leave the rolls for that reason. And the third is that there are ongoing reviews that can see whether the person still has a disabling condition, but those don't happen very regularly. The Social Security Administration doesn't have enough money to really do them as often as they're supposed to be done. And it can be very, very difficult to tell when somebody's condition has improved enough that they can go back to work. So it's tricky. So work is the main way that people leave the disability rolls. But very few people do leave for that reason. I think I've seen numbers that suggest that maybe 0.5% of people on the DI rolls each year leave because of work-related reasons, and maybe 4% leave within a 10-year period. So almost nobody's leaving for work. Nevertheless, SSA, the Social Security Administration, is kind of really trying everything they can to help people go back to work. The incentives to go back to work are horrible, because if you earn above a certain amount, above this $1,000 a month for enough months, then you'll no longer be able to get benefits unless you quit your job and have your earnings go below that level. So the incentives are really strong not to work. They've tried changing the incentives over the years. Oops. Okay, that's good. They've tried changing the incentives over the year. There's a national evaluation right now called the Benefit Offset National Demonstration, or BOND for short, that's testing a disregard that would allow people to work, and for every $2 that they earn, their benefits would go down by $1. So that's better than the system is now, whereas after a certain amount, for every $1 they earn, their benefits go down by $1. So that's another idea to encourage people to go to work that's just being studied. There have been a number of attempts with employment supports, a couple of early promising studies with youth that used transitional employment. So people got jobs where they may have had subsidized employment with employers, and maybe some supports to help them move into unsubsidized work. And that seemed to be promising. Some efforts with case management for adults had much more limited effects. The most promising study to date is something called the Mental Health Treatment Study, which has used something called supported employment, where individuals with severe mental illness, schizophrenia, for example, are given jobs in regular workplaces, integrated, meaning just regular workplaces, but they have something like a job coach who helps them with things that are going on in the workplace. And this has been found in a number of studies to be pretty effective. And in a recent Social Security study, employment increased by about 50% among the folks who are getting this. So some efforts. The study I'm talking about today, we'll see why in a few minutes, is one more attempt to try to find a way to help people return to work. So now I'll get to the issue that was raised, that one of the reasons health benefits could be important for a group of people with disability insurance is that you are eventually eligible for Medicare if you're on the disability insurance rolls, but it's 29 months from the time that you suffer your disabling condition to the time that you can receive Medicare benefits. So if it's January and something happens and you hurt your back and you no longer can work, it's going to be not January the next year or January the year after that, but July, I guess, the year after that you'll be eligible for Medicare benefits. A lot of people take a while to get approved for benefits, so there may be a shorter period once they actually receive cash benefits, but it's 29 months from the time that you suffer the disabling event to when you can receive Medicare benefits. And a bunch of people during this period have no health insurance. They just suffered, as I said, disabling condition. They have, in many cases, pretty severe physical or mental health, in all cases, pretty severe physical or mental health issues, but about 20% of them, according to the surveys, don't have any kind of health insurance. So it can be a pretty serious issue because healthcare needs are pretty high for this group. In the first year after coming onto the disability insurance rolls, the average person, I can't remember the numbers, has about 22 doctor's visits and 7 days in the hospital. So, again, not really that surprising, and their health conditions could deteriorate during that time if they're not getting all the care that they need. So the thinking was that if you can get people who don't have insurance to have health care benefits, and you can get them to go to the doctor and take care of problems, and rather than having them deteriorate, maybe they'll improve, and if they improve, then they may be able to return to work. Maybe a disability review will find out that they've improved enough, and they'll have to leave the rolls. So that's the tie. It's kind of an indirect tie in a sense, but it's unique to the idea that there is a period when people might be uninsured while they're waiting to be eligible for Medicare. That really makes this important. At the same time, the study started right around the time that people were starting to talk, right around the time, meaning for the last 30 or 40 years, that people were talking about reforming the healthcare system and trying to improve access to health insurance. And there's a huge literature on the relationship between health insurance and healthcare use and health outcomes. And a great paper by Helen Levy and David Meltzer that came out a few years ago said that they had reviewed, I think, over 300 articles trying to relate those things. And of those, this is The Economist in them talking, of those they found that about 10 of them really had something useful to say about the relationship between health insurance and health status and health outcomes, because the rest were really just correlational, comparing people who had insurance to people who didn't have insurance, and there were just all sorts of things that are going to be different between those two groups that made it hard to decide whether the differences they were seeing were really causal. But there were a handful of studies, about 10 of them, that were able to take advantage of natural experiments, like the fact that you become eligible for Medicare when you reach age 65. So there are a group of people who are uninsured when they're age 64, in 364 days, and then they hit 65 and now they have insurance, and you can see what happens to how much health care they use and whether their health improves. Likewise, changes in Medicaid eligibility rules have been another opportunity for people to look at variation in how much health care people use. And the evidence from these non-experimental studies suggests, I think nobody really argues too much that health insurance does lead to increased health care use. Even George Bush, who famously said that people without insurance can just go to the emergency room, thought that it changed the type of health care people were getting, even if it didn't change the amount that they were getting. The thing that's called into a little more question is whether there really is improved health. Some studies have found some increases in the self-reported health through surveys. There have been some indications that mortality goes down. One study looked at pretty sick elderly who, taking advantage of this idea that people get insured when they're age 65, and did find a 20% drop in mortality for that group. But as I said, there's great potential for selection bias, and the Levy and Meltzer study concluded that, if you look carefully, it looks like the evidence kind of suggests that health insurance is related to health outcomes for some subgroups, but it would really be nice to have better evidence of it. And that's kind of what makes me excited about this study, that it's one of the few randomized trials, one of the few social experiments to look at health insurance and health outcomes. After ours started, about a year after, a study started in Oregon where folks, they had an expansion of the Medicaid system, and I think it was like 20,000 people or something. A huge number of people were put into a lottery where some of them were made eligible for Medicaid and some of them weren't. And they came out with a working paper, an NBR working paper that I don't think has been published yet, a few months ago, that found that it did increase preventive care and hospital care, inpatient care, and that sort of thing, and there were improvements in self-reported health. We've been trying to say, ours though is the first study that ever randomly assigned people to have health insurance or not, but it hasn't flown in the journals for some reason. Like they know about the study and they don't want us to talk about it. The other experiment that everybody knows in this area knows about is the RAND health insurance experiment that took place in the 80s. It wasn't, though, an experiment that tested the effects of health insurance per se, because people were randomly assigned to different levels of generosity. So they had different levels of co-payments, for example. And some people had to pay, you had no co-payment, so they can get care for free, and some people had to pay 10% as their co-payment and that sort of thing. And it found a pretty clear relationship between the generosity of the health insurance people had and how much care they used. So if you're paying for more, if they had to pay less for their care, then they were going to use more of it. It didn't, however, find clear links between health insurance or the generosity of the health insurance and the health outcomes. There were some indications for some subgroups that health improved for some sicker people, but overall it didn't see a significant relationship between the generosity of the health benefits and their health outcomes. One nice thing about accelerated benefits is that it includes a group of people who do have pretty substantial healthcare needs, whereas the RAND study included a broader cross-section. So now we'll get into the details of accelerated benefits. Finally, 20 minutes in. So AB, just a quick overview of the design. It's a random assignment study. People were about 2,000 new SSDI beneficiaries were randomly assigned to 3 groups. One group is what we call the AB group. They got a set of healthcare benefits that I'll tell you about. A second group we call AB plus got the healthcare benefits plus some other supports that I'll tell you a little bit about, really designed to help them use the healthcare system, but also designed to move them more towards employment. And then the third was a control group, so no additional services. Eligibility was limited in some ways. We wanted to get, there's always this tension in doing these kinds of studies. Do you want to get a very broad group that allows you to generalize to, say, disability insurance beneficiaries more broadly, or do you want to get a group where you're going to see big impacts and really understand whether health insurance plays a role? We opted for the latter in this case because it costs quite a bit of money to provide people with healthcare benefits, and we didn't want to spend money and not see impact. So we opted to narrow it to people who were less than 55 years old. This was more because one of the goals was to see if we could encourage people or help people move to employment. If they were nearing retirement age, the fear was that they wouldn't go to work until they hit retirement age. I mentioned that it's 29 months from when you have an onset of your disability to when you can receive Medicare. We limited the sample to people who still had at least 18 months left to get Medicare. That meant that they were approved pretty quickly to get DI benefits. So just to make sure you understand the process, somebody can apply, somebody becomes disabled, and it may take them a little while to apply for benefits. They may apply and get denied, and then appeal again, and sometimes appeal again. It may take quite a long time for them to get approved. We're getting people who applied and were approved to receive benefits within 11 months of the onset of their disability. If it took longer than that, then they're not in our study. That means that we're probably getting folks who had more severe disabilities than some other folks. They had to live in one of the 53 major metropolitan areas, and that was just to get our sample in pretty quickly, but it also meant that we were all over the country and it was pretty generalizable. And then finally, these 3 things we were able to get from the Social Security Administrative Records, but then we did a screening survey to make sure people weren't currently insured. These restrictions mean that we weren't including in the study people who are on supplemental security income, SSI. About a third, I think, of DI beneficiaries also receive SSI. And the reason is that they're eligible for Medicaid for the most part, so they would have been insured in our study. Just people often ask about this, about how generalizable the results are. We started out with a group from looking at SSA administrative records that looked like they might be eligible. We did a phone screen, and we reached about, I think, 82% of people who looked like they might be eligible. 94% of them, I think, were, we got rid of a few of those because they had some issue that meant they couldn't provide consent to be in the study, like they had a psychological impairment that, or a cognitive impairment, rather, that meant that they wouldn't really be able to provide informed consent. But of the people who could provide informed consent, 99% did. So the offer of getting health care benefits was very attractive to people. And 99% of those completed a baseline survey. So it feels like this is a study that is pretty generalizable. In some of the SSA studies on employment, you find out that 10% of the people who are eligible actually agreed to be in it because they weren't interested in the intervention. Here's something that everybody really wanted to get. You can't really see the outline of the U.S., but these are the 53 sites that I would show it. Seattle is there. Uninsurance rates really varied a lot from place to place. So the number of people who came in different places varied. As you might expect, the uninsurance rates were highest in the South. So places like Oklahoma City, Houston, Dallas had more than 20% of the people we called were not insured, even though they had, were pretty sick in many cases. The insurance rates were the lowest in California and in the Northeast. So some places had insurance rates as low as 4%. Seattle was almost right in the middle, about 12%. We ended up dropping, Buffalo, it is there. We ended up dropping Buffalo because so few people were uninsured when we called them that it just wasn't worth making phone calls to get to Buffalo anymore. I'm not sure why Buffalo and not Rochester, or if they were going across the border to Canada and getting their health care. We also ended up dropping Boston because after we started the study, Romney Care passed, and we didn't think very many people would be uninsured, or if they were uninsured when they started the study, they would have access to other insurance later on. Just to give a quick overview, obviously these are people with severe impairments. 94% had difficulty with something called instrumental activities of daily living. This is things like being able to stand up for long periods of time or walk upstairs, things like that. A smaller percentage, 29%, had difficulties with activities of daily living. These are pretty serious things where you have trouble eating or getting out of bed or using the toilet. That's 29% had some pretty serious physical impairments that prevented those things. It's always kind of interesting to see the next number, that despite those impairments, only 47% said their health was poor. So 53% said their health was good or excellent. And the literature suggests that people kind of get used to their condition and are kind of comparing, how do I feel today to how did I feel last month or last week? You kind of get used to feeling that way. I know as I'm getting older, like my back is bothering me and things like that, and it just, it's bothering me less today than it was last week, so I feel great, even though I don't feel as good as I did 20 years ago. There's a lot of unmet medical needs, as you could imagine, among a group of people who are uninsured. 70% said they had some unmet needs. 64% hadn't been insured for at least 6 months. And then the last thing is just to say there were a range of different impairments. So it was a pretty broad set of folks as well. To give you a quick overview of the healthcare benefits that people were getting, they had access to a network called MultiPlan that's administered by an organization called POMCO in Syracuse, New York, that actually administers MDRC's health insurance plans. So we chose them because they were easy to find. It's a system with 450,000 providers around the country, and providers in every metropolitan area that it just showed, 4,000 facilities, hospitals, and other places. Just some features of the health plan. It covered most health care that you could think of. There are a few things that it didn't cover, like gastric bypass surgery to close your stomach to reduce obesity was something that they decided not to cover, which is kind of surprising because obesity is one of the things that we'll see later is tied to poor health outcomes sometimes. Co-payments were $12 for most doctor's visits, higher for hospital admissions or for you go to the emergency room and things like that. And one other aspect of it is that the health care benefits were capped at $100,000 over the time for each person during the time that they were in the study. So individuals were in our study for anywhere from 15 to 29 months, I think, and they could spend up to $100,000 in health care benefits during that period through accelerated benefits. When they got close to $100,000, somebody reached out to them to try to help them make it. Most of them would be eligible for Medicaid at that point, so somebody reached out to them to help them make a transition to another kind of health insurance. We didn't just decide in the middle of surgery they'd hit their $100,000 and that was going to be the end for them. Just to give you a sense, these are from claims data that were received for folks who had access to the healthcare benefits. Almost everybody had at least one claim, 88.7%. In the first year after entering the study had at least one claim. Mostly for doctor's visits. Diagnostic procedures were really big as well. A substantial number did have inpatient hospitals. Were admitted to the hospital. Prescription medications were a big thing as well. During that first year, the average claims were about $19,000 per person, most of it for hospital admissions. That's the big source of spending in the healthcare system in general. Despite the $19,000, one of the things that made this kind of a great program for encouraging people to use healthcare is that they spent on average $19,000 on healthcare, but their co-payments, out-of-pocket costs, were only $270 on average. So it was a pretty generous plan compared to what they would get when they get onto Medicare later on, probably. Just to give you a sense, this did vary a little bit compared to Medicare, compared to DI beneficiaries who are eligible for Medicare. Spending was about almost twice as high, 19,000 versus 11,000. And again, that's probably because we were getting people who were sicker because they were approved pretty quickly to get benefits. It was also probably because we were using a private health insurance plan rather than Medicare. So reimbursement to providers was greater than will be true under Medicare. But there weren't that many differences between AB and AB+. 12% had payments of about $50,000, but they made up 53% of the payments. And about 3.5% within the first year had already hit their $100,000 cap. And these are more likely to be people, one thing I glossed over, about 8% of the sample had cancer when they came into the study. So those are a lot of the folks who hit the $100,000 cap. Spending was higher if you had cancer. They averaged about $40,000 in the first year versus $17,000. Some small differences for other people if you had poor health, if you were obese, if you had a longer time until your Medicare eligibility, you tended to spend a little bit more on benefits. So the other part of the intervention was what we called AB+. There are 3 types of services, all delivered by telephone. One we called medical case management, but it wasn't really medical case management. It started out being that way, but it kind of changed. And the idea there was just to help people navigate the healthcare system, make sure they're going to see the right providers, make sure they're getting the care they need, and that sort of thing. It changed a little bit during the course of it, and I'll talk for 2 seconds about that in a minute. The second is a behavioral program called PGAP, for the Progressive Goal Attainment Program. And this was an intervention that was developed in Canada for folks in the workers' compensation system. And the idea is to take people who haven't worked for a while and who may have lost some of their motivation to work, who may feel a little bit deactivated, maybe sitting at home, not doing much, and try to get them to a point where they, try to get them to start doing gradual activities. Get up in the morning at the same time every day. Go for a walk if you're capable of walking, or if you're not capable of walking, do something else, like where you go out of the house and visit a neighbor, go to the mall, do something. And just try to get them to gradually move towards the point where they saw themselves as being able to do more activities and to be able to return to work. And then the third is we found that nearly 90% of people in our study couldn't really accurately talk about the incentives that they face regarding the relationship between work and benefits, but also somebody, and then a second person to help them understand what their career opportunities were. Again, these are people who recently had been working, so they were interested in work. Large proportions of folks in the DI role were interested in work, but they probably couldn't go back to the same kind of work they had before, so this is somebody to help them think about career options, things that they could do. All the services were provided by telephone. Here are some of the partners. This is just, so the PGAP thing was kind of interesting. It was based on a workbook that folks filled out, and one of the things they had to do, there were assessments that self-assessments they had to do at the beginning to get at things like how they perceived their own disability, how much pain they thought they had. I learned a new word in the study called catastrophizing. I don't know. There's concern that a lot of people have catastrophizing behavior, where you kind of see, they just think about things, everything is going to be horrible and think bad things are going to happen. And we realized, we started thinking about people we work with and who are the catastrophizers in our workplace, where everything is a disaster, and how do we avoid having to work with them. Another thing they had to do, this is all about the idea of getting people into regular schedules and getting them doing stuff. They were asked to fill out every day a log that says, here's what I did today. I got up at this time, here's, I sat in front of the television for 5 hours. This would be day 1. And then day 2, getting up earlier and going out and stuff like that. But it was a way of kind of helping people recognize what they were doing and then also helping to record their progress over time. We thought of these 3 services. I just want to make sure I get to some of the results before 1:30. We thought of, when we initially conceived of AB+, we were kind of thinking what would happen is that people would come into the study, they would have some pretty serious healthcare needs, so they would talk to a nurse who did the medical case management, and they would make sure that they were seeing the doctors they needed to see, that their care, their health was stabilized. And then the next step would be that they would go through this PGAP program. We call the person who did that a coach, and the coaches were mostly social workers, as an FYI. They would then, the next logical step we thought was that they would go through PGAP and go through this 10-week program that would help them realize that they could return to work and do more stuff that's work-related. And then they would be ready to talk to an employment and benefits counselor who could help them think about career paths and applying for jobs and all those sorts of things. And it turned out, in reality, people came in and they were just in all different places. Like some people were ready to look for work right away and they wanted to talk to an employment counselor. And some people didn't have, thought their health needs were pretty stable, so they just wanted to go into PGAP right away. And other folks did have some pretty serious health conditions. The other thing we found is that when we first started the study, we had the coaches at intake, see intake is there in the 3rd box. We had the coaches at intake do an assessment that included things like a depression scale, and there's all sorts of well-recognized scales to try to figure out what people's issues were and try to direct them in the right way. And we found out pretty quickly that this was leading us to, leading the staff to get people, they were getting distracted in a sense by their healthcare needs. It was a bad way of saying it, but we were hoping that the ultimate goal was to get people employed. And what would happen is somebody would come in and they'd have some, indicate some healthcare needs. They would be referred to a nurse, and the nurse is, normally is thinking about things in terms of how do I get somebody to talk to the right healthcare provider and that sort of thing, rather than thinking about how do I get this person to get the care they need, but get them to a point where they can start thinking about employment. And we found that the nurses were focusing too much on the medical needs of people and less on this idea of trying to get them to a point where they can start thinking about work. We didn't want them to ignore the medical needs, but we didn't want them to be really, really heavily focused on them. So we changed the system a little bit after a short period of time to get people to refer to nurses only under 5 conditions. And one is if they were depressed and they looked like they needed some help with their depression. And that's where one of the examples of where having this be designed by 3 mental health professionals played a big role. I mean, one of the things we heard related to they're focusing too much on their medical care is that a lot of the people were taking too many pain medications, and we just needed to get them off pain medications. So another one of the conditions is if for some reason there was some indication that the person was over-sedated, they were taking too many pain medications and they couldn't really function. This is something the mental health professionals thought was going to be a huge problem. A third, fortunately, was if they really had a very serious medical condition. If they were terminal, if they had cancer, if they had some other critical condition, then they were referred to the nurse to make sure they were getting care. And now I've forgotten the other 2, but those are the 3 most important. But the idea was really only if they had something that was, a fourth was to just give an assessment to make sure that there wasn't something that was going to keep them from getting into PGAP. But the idea was to make it less about really managing people's medical care and more about making sure they have the right care, but helping them get ready for employment. Most people use some aspect of the AB Plus services. 2/3 use something. About 35 to 40% use each of the 3 types of services, and that's actually not bad. It doesn't sound like a huge number, but surveys indicate that about 40% of folks on the DI roles are interested in returning to work. I've seen numbers as high as 80%, but I've seen numbers mostly around 40% are interested in the DI roles. So 40% here are getting some services related to employment is actually right on target for what you'd expect. It wasn't a huge amount of effort. Overall, the average person was only in these 3 things about 3 hours over the first year, so it wasn't like they were spending huge amounts of time. This did include only time when they were actually actively on the phone with a coach or a nurse. So if they were at home doing self-assessments in PGAP, or if they were filling out the log, that doesn't count toward this time. About, just thinking about PGAP in particular, about a little more than half completed at least, there were 10, supposed to be 10 weekly modules of PGAP. A little over a half completed 4 or more of them, and 4 was what the developer thought, was kind of a minimum, for getting something out of it. And about 1 in 6 completed all 10 sessions. There were some barriers to participating in AB+, some that you might expect. There are 2 sets of figures here. One is for people with fair or better health versus poor health, and the other is for folks with neoplasms or cancer versus folks without neoplasms. And not surprisingly, folks who had cancer are a lot less likely to use PGAP and in general be interested in returning to work. And not surprisingly, people with cancer were a lot more interested in the medical case management and were more likely to use that. Another thing that seemed to be related to whether people were participating in AB+ was just their literacy, if you look at education or other indicators. That may be in part just because there may have been less of a focus on employment for those groups, but also some of the things, especially in PGAP, were harder to do if you had trouble reading, or had some literacy issues. Filling out the workbook, it'd be hard. Doing the self-assessments was a lot harder if you had trouble reading, and it was hard to deliver those by phone. Okay. So what effect did, any questions? So what effect did this program have? I'm going to be presenting results just through 12 months of a survey that was done around 12 months. The only outcome that doesn't come from the survey is administrative data on deaths that SSA collects because they have to figure out when to stop sending checks to people. So they have pretty good information on that. And the outcomes include health, all the things we talked about, healthcare use, their health level and functioning, and finally employment, services, and employment. And what we expected to find is that we expected the healthcare benefits by themselves. Some folks were randomly assigned to just get the healthcare benefits, and we had a control group. So you can compare those 2 groups to understand what the effects of the healthcare benefits alone. And we expected to find increased healthcare use, reduced unmet needs. So you'd have fewer people saying they just couldn't go get the care they needed because they couldn't afford it, for example. We're hoping that would lead to improved health and functioning, and that would in turn lead to improved, people looking for work and maybe returning to work. And way down the road, all of those things are supposed to lead to people leaving the disability insurance rolls, but that's because of the rules of the disability insurance system. That would be several years down the road before that happens. The other is that if you're AB+, we wanted to know, do those 3 sets of services, did the medical case management change the healthcare that people were using? Did they use different kinds of healthcare and so on? And did the PGAP and employment and benefits counseling lead also to more job preparation and more employment? And all of this again in the first year. One of the things to keep in mind as we look at the results is that it's a survey-based thing, and as you'll see later, about 5% of our sample died in the first year. So obviously this is limited to people who kind of a weird thing to say, but it does affect the results to know that it's limited to people who lived for a year after they started receiving the rolls, after they got on the rolls. So some of the measures of health, for example, would have been different maybe if we had surveyed people a few months before, and some of them were still alive. So the first question is whether it increased healthcare use, and the answer is, pretty convincingly, there's a pretty big increase in healthcare use. So one thing that's not shown here is that about 80% of the control group said they had some kind of use of the healthcare system. They saw a doctor at least once. I should mention also that about 40% of the control group did at some point in the first year have some type of health insurance for at least a day. We don't know how long it was or what kind of health insurance, but we do know that at least 40% had health insurance for a little bit of time. Most of them not for very long, because at 6 months the rate was much lower than that. But that may be part of the reason that 80% of the control group was able to see a doctor. 40% of them did have insurance, so a bunch of them had it paid for. Here, there are 4 outcomes shown. In each figure that I'm going to show in the next 4 sets of slides, the leftmost bar is for the AB+ group, the middle bar is for the AB group, and the rightmost bar is for the control group. And these are all percentages, so obviously taller bars are good, and bigger differences between the first 2 bars and the third bar is an indication that the program was effective. So a couple of things to point out. One is that it was effective. About 75% maybe of the control group had a regular source of care, but about 90% of the AB and the AB plus groups had a regular source of care. So that's a pretty sizable increase. I think the thing that struck us really was that 75% of the control group had a regular source of care, and even though fewer than 40% had insurance at most times during the year. So people were getting other sources of care. They were going to federal clinics, or they were getting they were paying for it out of pocket. There may have been some charity care in here, but these again were folks who had to have seen a doctor relatively not that long ago, because to get onto the DI rolls they had to have a doctor assess them and indicate that they had a disability, and they also had a lot of need for care, so a lot of folks were getting care even if it wasn't being paid for by somebody else. Regularly takes medication, similar numbers, about 70 to 75% versus about 90%, so pretty substantial increases. Underwent surgery, another big place. Surgery is one of the most expensive things that could happen, so you see a pretty substantial increase from about 20% to almost 35% for the AB and the AB plus groups. The one thing you don't see here is much of a difference between the AB groups and the AB plus group. There really were very, very small differences in the healthcare that people were using. So the medical case management didn't really have much of an effect on the types of care that people were using in these broad categories. It may have had an effect on very narrowly defined categories, but not on these broad categories. But again, we're calling it medical case management, but it was a very, very light touch when it comes to that. A more intensive case management program might have changed the kind of care that people were using. The last thing that was kind of interesting is that there was really no effect. The control group and both AB groups had about the same levels of use of the emergency room. And this could have gone both ways, because one of the arguments is, one of the things that's been happening in the healthcare field over the last 5 to 10 years is that people are really trying to encourage the use of preventive care, the use of medical homes, or now they're called health homes. Make sure that people have a place where they can go to get their routine care, so they're not going to the emergency room, as George Bush thinks they were doing. But on the other hand, here this study paid for them to go to the emergency room. If they went to the emergency room, they had a copayment, but if they had a serious emergency, they could go and not feel like they were going to go bankrupt paying the hospital back for the care they were getting. So it kind of cuts both ways, and those two things probably just kind of canceled out, where they went when they had an emergency, but they also had a regular doctor they could go to. They had a regular source of care that they could go to and get care. The stars indicate, in case you can't read the footnote, those are things that there were significant differences between the AB and the AB plus groups and the control groups at the 1% level. So the next question was how much it reduced unmet medical needs. And here the issue that was kind of important is that a lot of the measures of healthcare use were very broad, like did you have at least one doctor visit in a whole year's period of time? Did you go to the hospital at least once? Did you get one prescription medication filled? But it didn't really get at the intensity of the use. So we asked people whether they were having all of their medical care needs met, or whether they felt like there were still some unmet needs. So we just asked them a broad set of questions like, did you ever need to go to the doctor and not go? Or did you ever need to get a prescription filled and not have it filled? Or take less than the prescription indicated that you were supposed to take? We also asked them for the reasons, and in particular we were interested, because we were providing them with a way to pay for their health care, we were interested in whether we saw fewer unmet needs because of costs. And what you see are huge reductions. So it's not just that they were going to the doctor more often, but a lot more people were getting saying that they got all of their medical needs met. So in the first set of bars, you see that about 70% of the control group said they had any unmet medical need for any reason. It could be that they just didn't have transportation to go to the doctor, so they were having a need that wasn't met, compared to about 50% of the AB and the AB plus groups. When you focus it just on cost in the second, I guess I can use this, in the second set of bars, when you focus it just on cost in the second set of bars, you see that it's still about 60% of the control group who said their unmet need was specifically due to cost, but only about 20 to 25% of the AB and the AB plus group. So that's where you really see the big effect. And as an economist, it's nice to see the relationship between cost and behavior. You also see a huge effect on unmet needs due to medications. 70% of the control group compared to about 35% of the AB and the AB plus group, so they had an unmet need due to medications. And it was somewhat surprising in some ways, because I glossed over it earlier, but the copayment for generic prescription medications was only $5 under the AB health plan. It was more if you wanted to go off, off the generic thing. There were some that were $10 and some that were $15. And $5 doesn't seem like it should be discouraging people from getting medication. But it turns out when you do surveys of people who are low income, that $5 can be a substantial barrier to getting their medications. And then finally, one big question is how much did that affect their out-of-pocket expenditures? We saw that in AB and AB Plus, the average was only $270 per person in the first year, and you do see significant differences. This shows the percentage of people who had out-of-pocket expenditures of less than $1,000. And only about 30% of so zero would be less than $1,000, just to be sure, zero's in here. So only about 30% of the control group had expenditures of less than $1,000. 70% had expenditures out of pocket of more than $1,000, compared to about 50 to 60% of the AB group and about 40 to 50% of the AB plus group. So not surprisingly, there was a pretty substantial reduction in how much they were paying out of pocket. We were a little bit surprised to see the difference between the AB and the AB plus groups, that there were just a number of really small, insignificant differences that added up to something that was significant. And it may be those nurses who were getting them into too much care at the beginning of the study too. Then the next question is, we're seeing more care. Did it improve their health and functioning? And the answer is it did, but not as much as the health care that they were getting. One thing we asked was just whether they thought their health was good or better. We heard that majority of people said their health was fair or better at baseline. At follow-up, only about 20% of the control group said their health was good or better, compared to about 25 to 30%. So there was a small increase in whether they reported this. It's kind of a weird question, just one question, how is your health? But it's really a pretty good predictor of how much people spend on the healthcare system, surprisingly. Then we had two scales that come from something called the SF-36, which is kind of a well-developed, well-validated measure of health and functioning that gets at 8 subscales related to physical and mental health functioning. And here I present 2 summary scales. You see not much of a difference across the groups in their physical functioning. It turns out that the difference between the AB and the control groups was significant at the 10% level on the physical functioning scale, but so maybe there's a slight indication of something on physical, but there's a bigger effect on the mental functioning scale. So their mental health, seemed to improve. It's kind of useful to have this come from the SF-36 as well. So they weren't just asked, how do you feel about your mental health? It was something that was getting at it in a more subtle way. So you do see improvements. What's kind of interesting about that is that you don't see, I didn't talk about this, but we didn't see any differences between the 3 groups and how much mental health care they received. So they were no more likely to go see a psychologist or a psychiatrist or a counselor or anything like that. I don't think they were any more likely to get, antidepressants or other medications. So it's a little bit of a mystery. Our best thought is that just having health benefits improved people's mental health. It just took a source of stress away from them and made them feel better. And maybe AB Plus had bigger effects because they also had a coach that they could talk to anytime they needed to. So just having those kind of supports there. Then the last thing I show is just whether people died after random assignment. And it's not significantly different across the 3 groups. That's the most important thing. But that wasn't true. What we presented it because we had some early results where there were significant differences in death. And we actually started thinking about, should we end this study? Because we're sending people to the doctor and they're killing them. And we were worried too, because this is going to come out in the middle of, or it ended up coming out right after the discussions about healthcare reform. But the idea that we were going to show that healthcare killed people was going to maybe put a little bit of a dent in the discussions about healthcare reform. There you go, death panels. And it's, this literature is so huge. There are studies that find that argue that healthcare does kill people. And Atul Gawande, who's become really famous, published something where they found that having people stay in the hospital if they had cancer, end-of-life cancer, compared to going to a hospice, actually killed them several weeks earlier. They died several weeks earlier if they were still in the hospital. And people go into the hospital, they get all sorts of viruses and bugs and that sort of thing. So there are all sorts of complications that can come from medical care. Fortunately, we didn't kill anybody. We also looked, was there a link between when people we saw a big increase in surgeries, were they going in and having a surgery and never leaving the hospital? or things like that. There wasn't any kind of link like that. Were we getting people through PGAP, to go out for a walk and they had a heart attack and that's how they were dying, and there wasn't any kind of link like that. So we felt a lot better at the end, and the statistical significance went away, so we really felt better about that. And the final question is, did all of this lead to more people going to work? And there are two answers to this. So there are three outcomes here. One is whether they sought employment services on their own that would help them go to work. A second was whether they ever looked for work, and a third is whether they were ever employed. There are three answers, actually, I guess. One is that the healthcare benefits by themselves didn't have a significant effect on any of these three outcomes. So just getting the healthcare benefits and being healthier didn't lead to increased job preparation, didn't lead to increased employment. But the AB plus services, these stars are really hard to figure out what they're talking about, but the stars are for the comparison between AB plus and, and the control group, really. It's the added effect of the employment services and the medical care management. And they did significantly increase. They pretty much doubled from 5 to 10% of the sample, the percentage who received any employment services. And they increased significantly, but at the 10% level, so not a huge increase, the percentage that ever looked for work. So it does look like the employment and benefits counseling and PGAP were somewhat effective in getting more people to work. These look like small numbers, but in the disability world, this is a pretty huge impact, potentially. Since these results came out, the Social Security Administration has taken a peek at some of their administrative data. I haven't actually seen the numbers yet. They just haven't had time to write them up. They say that you actually do see through the administrative records longer-term increases in employment. So they're able to look like 2 or 3 years out. And they do see some indications that, this did lead, 80 plus did lead to improvements in work. And they are taking some of the lessons that we learned about how to provide employment and benefits counseling by phone and trying to think about ways that they can change their own systems to help with that. For some reason, they're really excited about the employment and benefits counseling by phone, but they really were not excited about the PGAP by phone. And that's the place that we're really excited, because it seemed like that was something that was really, had the potential to help people if you could get them to go through that program. The last thing I just wanted to point out, since we're at the West Coast Poverty Center and I'm an economist, is that all of this also seemed to make people economically better off. We saw the reduction in co-payments. They also said they had fewer difficulties meeting living needs. So this is things like being able to pay the rent or mortgage, being able to pay utilities, having their telephone service cut off, being able to buy enough food. And we see fewer people in the AB and the AB plus group saying they had problems with those things than in the control group. It's still pretty high, 60% in those two groups, but at least it's fewer than in the other groups. So that's another positive aspect of this. So what was the cost of doing this? The cost of just the AB health plan was a little over $30,000 per person. So it's a pretty substantial chunk of money for providing these health benefits. So again, we saw it was $19,000 just in the first year, $30,000 over the 15 to 29 months that people would have been in the study. We hear all about how horrible administrative costs are for the private healthcare system, but here most of the costs were actually for providing healthcare and not for paying POMCO to administer the healthcare benefits. The AB plus services cost about $3,300 on average to provide, and most of that, like half of that, is for employment and benefits counseling. It just turned out the salaries for our employment and benefits counselors were pretty high, so they spent a fair amount of money on that, even though they were spending no more time with people than like the PGAP folks. So $30,000, keep that number in mind. A big question, one of the big remaining questions is just now that we see some evidence that people are healthier, maybe there's an inkling that they're working a little bit more, what's going to happen down the road when people end? They have already ended, but when they start receiving Medicare, does their improved health, does the fact that they were able to get some of their healthcare needs met early on mean that they'll spend less on Medicare down the road? Does the fact that some of them are going to work mean that a few of them will leave the roles down the road? It doesn't take a lot of people to leave the disability insurance roles to make up for a cost of $30,000 per person, and that'll be something that'll have to be investigated down the road. So just a quick summary, it seemed like these are really promising findings, increases almost across the board, not so much on the employment side, but definitely in healthcare use and health outcomes, but the results are still early. These are all in the first year. And longer-term impacts would be informative for the reasons I say. Just a few implications. One of the things that really excited us about this study, as I talked about earlier, is just that it's one of the few really rigorous studies of the effects of providing healthcare benefits. And so, it's one of the, now I'd say 2 studies that really show a very undeniable link between having health insurance, healthcare benefits, and improved health outcomes, along with the Oregon Medicaid study. But it also shows that improved health alone is not going to be enough to get people to return to work, but maybe these employment supports will help. A third implication is just the possibility of providing some of these services by phone. We did it because we had folks in 53 metropolitan areas around the country, and there was no way to pay for people to be located in all of those 53 areas. But for the same reason, the Social Security Administration could be potentially saving resources if they could find ways to do some of that by telephone. We do think that the PGAP program probably, it was designed to be done in person, and it's probably the sort of thing that is easier to do in person. You'd see bigger effects and more consistency. We're doing another study now of PGAP for folks in the VA, the Veterans Administration System, where we'll be in person and we'll see what kind of effects it has there. And then finally, ending the waiting period, giving people eligibility for Medicare immediately is going to be pretty expensive, but it's going to have some positive effects. And as I said, we'll have to look long term. How expensive it's going to be is a little bit unclear for some of the reasons I talked about. One is just that the group of people in the study was pretty representative of this narrow range of people who had at least 18 months until they were eligible for Medicare and were new DI beneficiaries, but it's not representative of most of the rest of the people who don't have health insurance in the country. So you wouldn't use it for that situation. Another thing, as I mentioned before, the multi-plan network that folks had access to is more generous than Medicare or Medicaid. So ending the waiting period would probably be less than $30,000 a year for people just because Medicare doesn't pay doctors as much. I think I've seen estimates that Medicare reimburses at about 30% less probably than the thing that we used. And it may mean that reimbursing doctors less may reduce the access to care and reduce some of the impacts that we've seen as well. A third reason that would go in the other way, though, is that there's a concern. Part of the reason that we have the waiting period in the first place is that there's a concern that getting access to health insurance is going to attract people onto the disability rolls. And so it's kind of meant to discourage people in some sense, really make sure they have serious needs. And there's a concern that ending the waiting period is just going to be something that's going to attract even more people to apply and get benefits, and that's a cost that we don't see. In addition to the idea that some folks who do have insurance when they start on disability insurance might drop their insurance. If it's something like COBRA or something that they're paying for, they might drop their insurance and sign up for whatever they were able to get in the Medicare waiting period. So the cost that we're putting here may be even greater than, or the cost of a rail system may be even greater because of that entry effect. All those things are just speculation, though, and we don't really know for sure what the cost will be. And now that the ACA, assuming the ACA passes the 2 big hurdles of the Supreme Court and potential Romney administration, then ending the Medicare waiting period isn't quite as, it'll still be talked about, but it's not quite as pressing as it would have been, because a lot more of the folks in our study would have access to Medicaid through expansions that are coming through the ACA, and others would have access to insurance through the health exchanges. So that's it. If you want more information, there's a report on our website. There's an article coming out in Medical Care that talk about all of the impact findings, but not as much of the implementation stuff. The report will have a lot more about how we implemented the study and changes and that sort of thing. If you're interested in, and feel free to shoot me an email. Thank you. You're welcome. No, we don't really have any data to talk about why it wasn't getting more. I mean, I think part of it is that there was a lot of care already being used, by the control group members. So, and the AB obviously was using a lot of care. The other is that I think it was, as I said, we kind of changed our conception of it not too long into the study, where it was less about the sort of things you would think of as, we actually feel a little bit, we don't really want to call it medical case management, but we started calling it that at the beginning, and then there was some concern that people would get confused if we changed the name in the middle, so we kept calling it that. It wasn't as intensive as you'd expect a medical case management thing to be. And if you looked at one of the things, I think people probably spent an hour or 2 hours on average talking to the nurse about their medical care, so over the whole year. So it just was a really light touch, and it was really, the nurses spent a lot more of their time trying to get people ready to go to PCAP. And just, making sure that if they had mental health issues, that they had a plan to deal with that, to go see a mental health professional, although we didn't see impacts on mental health care, so that probably wasn't the place where they were effective. But I think partly it was probably because it was delivered by telephone. I know the studies of care management that I've seen where you see the biggest effects, there's a lot of in-person contact. This was all by telephone, so probably harder to have an effect on that. No, I think that's definitely right, and people were very concerned about, not only in this study, but in other studies of telephonic care management and other stuff, just about how hard it would be to develop a rapport with, the person that they were talking to, and, would they even pick up the phone, because they didn't really know them very well, and that sort of thing. So it was definitely something that was a concern. The coaches and, the counselors did have concerns about that, and they spent, I didn't mention this, they spent a lot of time making phone calls to try to get people. Like, just for intake, for example, the average person took almost 6 phone calls to just get them on the phone and do, the intake process. So partly it's just like they signed up to get healthcare benefits. They didn't sign up to get services, so it probably took a little more effort to get them on the phone, and somebody was calling them from, I don't know, I never answer the phone anymore if I don't know who's calling me. So I'm not surprised that people might not have answered the phone if they didn't know who was calling them. And so it may have been that first step may have been the more difficult, and maybe in person, if they were actually coming someplace and meeting you, that would have made it a lot easier. Another thing that we found trouble with is that folks, said they were interested, or they got to the point where talking to a benefits counselor would have been useful, and they were given a phone number and a name and that sort of thing, and almost none of them called. So we changed the system so that if the coach thought it was time for somebody to talk to a benefits counselor, they just transferred them, on the same phone call and initiated stuff, and that worked a lot better, and you got a lot more people getting benefits counseling. But it's definitely part of the trade-off. I mean, we did it because we had to, but we kind of viewed it as an opportunity. If you could find that this low-cost way of doing things works. I have to say, in other contexts, like the group health folks that I talked to have done some studies, and we've done a study of telephonic care management for people with depression, and there are circumstances like that where it does seem to work. In those cases, there's like a really structured protocol about what's going to happen on the phone, how often they're supposed to call them, and that sort of thing. And the folks doing the calling are all mental health professionals. They have master's degrees and in a field that's going to make it appropriate for them to assess somebody's depression and to work with them. And that does seem to be show some signs of effectiveness. And it may be that they're better at developing a rapport, or I'm not sure. It's also, I think, one of the struggles here was that such a broad set of folks with so many different needs that it was really hard to be able to address all of them. It really required a lot of judgment, whereas having that really kind of narrow, protocolized thing seems to be a place where telephone might be less of an impediment. On the impacts of the program, like how much healthcare are they using, the impacts on how much healthcare they're using, the impacts on health, the health outcomes, we didn't see any differences by any of the indicators that we looked at by their self-reports of how healthy they were by the cancer versus other, but there just weren't big differences across any of those. So it's an interesting point. We thought we would probably see more, but it seems like it worked kind of across the board. I mean, like, how do they choose 29? Or just the waiting period in general, or why is it 29 months? I mean, the reason to set up the waiting period in general, I think, as I said, nobody really knows. I mean, it's something that was part, when Medicare was developed in the 1960s, this was part, and disability system was put into place. This was something that was part of it, and nobody is really sure, like, legislative historians look back and try to figure out how this came into place, and I don't think anybody is really sure. But the justification I've heard most often is that it is actually a way to discourage people from applying for benefits and to reduce costs. It's 29 months because it sounds like a weird period of time, and it is a little bit, but it's 5 months from when your disability happens, when the disabling event happens, until you actually can receive cash benefits. So if you hurt your back, in January, you're not going to be able to receive cash benefits until 5 months later in July, or June, I guess. You may be approved in February, but you have to go 4 more months without any cash. And then from that end of that 5 month period, it's 2 whole years before you're eligible for Medicare. So it's often talked about as a 2-year waiting period, but there's really this 5 month period, at the front as well. But the other thing, I think it's to me a little bit of a mistake too to think about it just in terms of costs. because people have health care. We don't, my employer provides health care, and he's not doing it because it's going to save him money. He's doing it because it's the right thing to do. And we provide Medicaid and other forms of public health insurance for that reason.